My name is Leland+L+Fan. I'm from Denver. So, and you know, we're not quite as smart as those guys at sea level. Um, I just want to say that I'm very grateful to be here and to be able to talk to you. And I've been coming to these meetings ever since the beginning. I only missed one. That's when my mom died, so that's what it would take to get me not to come. And the first time that we had this meeting in Cincinnati, there were 5 families. And that was the origins of the Child Foundation. So I know you've know this, but it's just really exciting to see how the foundation has grown. And every year we get more and more families, and it's just wonderful. So Ann asked me to talk about the child recommendations for oxygen therapy, and I'm not sure if we polled the Child Research Network, we would actually get consensus. So I guess I just have to give you my opinion. This is the only disclosure that I have. And as you know, the children's interstitial lung disease is a diverse group of rare lung disorders characterized by diffuse changes on chest X-rays, and they are often associated with low oxygen levels. And this is a study that I kind of harangued Lisa Young in the back last year when we were talking about oxygen pro-con. And but this study was a series of infants less than 2 years of age, and one can see that the vast majority of the infants studied were hypoxic. And so the need for oxygen is very common in this group, as you know. And this is sort of the only published guidelines that I know of that address home oxygen in children. So this is the British Thoracic Society, and they make recommendations that long-term oxygen therapy should be offered to hypoxic children with interstitial lung disease who are otherwise ready for hospital discharge. And then likewise, if the diagnosis is obliterative bronchiolitis, which I know some in the room, their children carry this diagnosis, the same is also true for that diagnosis. And why is oxygen important? So Bernie gave you a very elegant case for using oxygen to reduce neurologic complications. But one of the other complications that's of most concern is the development of pulmonary hypertension. So according to the BTS guidelines, hypoxemia causes pulmonary hypertension, but the precise severity and duration of hypoxemia needed to do this is not known. The factors affecting individual susceptibility are also unknown. So therefore, the recommendation is actually to keep the O2 saturations high in patients with pulmonary hypertension, so probably higher than what people would ordinarily recommend if you just had low oxygen levels. So at least 94 to 95%, and the feeling is that if the saturations are less than 90%, that this may contribute to the development of pulmonary hypertension. So this recommendation, according to this group, did not apply to patients with cardiac defects and another condition called idiopathic pulmonary hypertension. And how does that work? Sorry, I don't know why I'm losing my voice. Low oxygen levels actually cause the pulmonary arteries to constrict. And this is advantageous if you have a local area that's not working. So if you have an area of pneumonia and that area is not receiving oxygen well to the lungs, then the body's attempt to fix that problem is to narrow the vessels and divert the blood to the better oxygenated part of the lung. So it's kind of a defense mechanism that the lung uses, and we call that autoregulation. However, if you have diffuse lung disease, then you start developing diffuse narrowing of those blood vessels, and the blood has nowhere to go, and so the blood pressure in that system will rise. So So this is a scoring system that I developed a long time ago that just clinically seemed to be useful to me, and how I thought, why is one patient sicker than another patient? And so the increasing score denotes more severity, and it's based on the need for oxygen. So, for instance, if you look at score 3, these patients need oxygen either while asleep or with exercise, but they don't need it when they're awake. And score 4, they need oxygen all the time. And then score 5 would be that, plus they also have evidence of pulmonary hypertension. And in a study that I did a long time ago, this score seemed to be useful in relating to outcomes. So the patients that had the higher scores, particularly score 5, did not do as well as those that had a lower score. And I would say that the one notable exception to this rule is patients with knee high. So patients with knee high often, at least initially, would score 4, and you would think, oh, that's not a good score to have, but generally those patients do well. And so I think that's one notable exception to this scoring system. So the BTS guidelines again discuss the consequences of low oxygen saturation, and as Bernie has elegantly described, there are significant effects on cognition and behavior, and also growth can be disturbed. So I highlight those two things in red. And here's an old study that looked at the growth of patients with BPD. So this study actually took patients and they weaned them off of oxygen when they thought they were ready, but one group actually had a lower saturation when they did that compared to the other group. And while they were on oxygen, you can see that the growth rate was comparable in the two groups, but when they took group 1 off of the oxygen, their weight gain, 3.7 here, diminished compared to the group that had the higher saturations at baseline. So this implied that patients who have low oxygen actually don't grow as well as those that have higher levels of oxygen. And the other part of the study was that the awake saturations did not predict the saturations during sleep. So when they were weaned when they were awake because their saturations were adequate as deemed by these doctors who took care of them. But if you can see, this is the saturation measured in the clinic when the patients were there for, they had a 20-minute measurement, and this is their saturations during sleep. And the vast majority of them awake in the clinic had what we would consider adequate saturations, but when they went to sleep, you could see a wide scatter, so a number of them desaturated during sleep. So an awake saturation in the clinic will not predict who's going to desaturate at night, and this may actually have impact in terms of weight gain. That's the net message from this study. So what is the minimal sat that will prevent these complications? And so you've heard several opinions, and I could put mine in, but I really think we don't really know. So is it 90%? Is it 92%? Is it 93%? Is it 88%? I don't think we know. And so then you have to ask, well, what is the risk of oxygen therapy? So if there's a risk for complications from low oxygen, and we therefore want to apply oxygen to these patients, do we do it liberally or do we do it conservatively? And to answer that question, you have to ask, well, what is the risk of oxygen therapy? So there are two risks. One is that premature babies are at increased risk for eye toxicity. We call this retrolental fibroplasia, but really this is a disease only of preterms. And so once you hit term or beyond, this risk goes away. So for your children, there is no risk for this eye toxicity. But there is a risk if you breathe too high a concentration of oxygen into your lungs, and this has been well shown in animal models, and that number seems to be somewhere above 60% oxygen. So if you breathe high concentrations of oxygen, even for relatively brief periods of time, you can develop changes in your lungs that are consistent with oxygen toxicity. And this is felt to be related to the free radicals, the free oxygen radicals that are released when you're breathing these high concentrations of oxygen. So then the question is, well, if my child is on a nasal cannula, can they breathe these high concentrations of oxygen? And the answer is really no. And so this is a study that I did a long time ago, looking at how much oxygen can you deliver to a patient at any given liter flow. And I won't go into the details of how I did this. This was an estimate. It was an indirect measurement. But in premature babies, so I divided this by weight, less than 3,500 grams, which would be roughly 7+ pounds. There was a higher level of oxygen delivered even at low liter flows. But in older patients, there was a less oxygen delivered per liter flow. So for these here, up to 2 liters, there's only one data point. This was estimated to be somewhere between 30 and 35%. And the reason why this occurs, that there's that at older children get less oxygen at even higher liter flows, it's related to something we call inspiratory flow rate. So older children, when they take in a breath, their inspiratory flow rate is much greater than a premature baby who's breathing very shallowly. And so when that patient breathes in the oxygen at a high inspiratory flow rate, the oxygen that's delivered is diluted down. So you entrain a lot of room air, which dilutes it down. So premature babies who are breathing shallowly have a low inspiratory flow rate will get a higher level of oxygen per liter flow compared to older children who dilute the oxygen down. And the older they get, the bigger the inspiratory flow rate, the less oxygen they're going to get at any given liter flow rate. Does that kind of make sense? So, you know, at the levels of oxygen that we're talking about, a half a liter, 1 liter, even 2 liters, I don't think you can get more than 30 or 35% from those flow rates. And so I believe, we all believe that this is a safe concentration of oxygen to breathe. Okay, when to wean. So, you know, it's easy to put patients on oxygen. Sometimes it's harder to get them off. But in general, we want to see the SATs consistently above a certain level. So in Denver, we would accept 90%. We want to see the patients gaining weight well and that they have no evidence of pulmonary hypertension. And then what do you do with patients who feel better on oxygen, but they have SATs greater than 90%? So sometimes we have patients who have consistently, you know, adequate saturations, but maybe they breathe fast and they don't feel right. And sometimes I get this story enough that I believe it. When you give them oxygen, they feel better or their respiratory rate slows down. Maybe it cuts their work of breathing down. So I would support giving oxygen in that situation, although it's a lot harder to sell an insurance company on that kind of thing because, you know, they have their criteria and the SATs have to be less than this. But I think that I would favor doing that. And then the final thing I'd like to address is what about flying? So probably a lot of you guys flew here, and many of your children flew with oxygen, so you could probably tell me a lot more about that experience and what it takes. But in general, most planes are pressurized to around 7,000 feet, the equivalent of being at 7,000 feet altitude, and there is a maximum of 8,000 feet according to the websites that I looked at. And this is the same as going to Evergreen, Colorado. So when you drive from Denver into the mountains, you hit the foothills and you keep going up and up. And not too far from Denver is a town called Evergreen, and it's roughly around 7,500 feet. So, so patients with a child who fly, they may indeed need oxygen, even if their room air sats are normal at sea level, of course. And if they are already on oxygen, they may very well need more oxygen. And so how do we make this determination? Well, there's really not a good way to do that, but what is published in the literature, and this is very common practice in England, Australia, Europe, they do what's called a hypoxic challenge. So they'll take a patient and they'll give them 15% oxygen. So room air is 21%. So they give a hypoxic gas mixture for 20 minutes. And according to this test, if your saturations drop below 85%, then the recommendation is that you should fly with oxygen. And actually, I can't find any studies that have validated this. So actually, these certain patients fail the test, and then they need oxygen. So how did they do on the plane? Or those that pass the test, they get on the plane. How did they do on the plane? So that would be a pretty simple study, I think, to do that I have never seen. But this is kind of the way that the test has been done and is commonly done in Europe and other places. And in Denver, we kind of have this natural way to challenge patients. So I actually tell my patients to do the Evergreen Challenge. And so I tell them, you bring your pulse ox and you bring your oxygen and you drive to Evergreen, so it only takes like 20 minutes to get there, and you observe the symptoms and you measure the SATs. And if the patient becomes symptomatic or the SATs fall below, in my case, I say less than 88%, obviously, I would give the oxygen and to see if you could get the SATs up, and it would relieve the symptoms, and that's the amount that you would use for flying. And if you get into trouble, you come down as fast as you can come down. And that doesn't happen very often, but so I think that's a nice way to do it. You know, we have the luxury of being near the mountains to try that. And the problem with the hypoxic challenge is there's not an easy way to tell how much oxygen you will need if you fail the test. So you can't give the hypoxic challenge and the oxygen at the same time. You know, it's a hard thing to do. So this seems to work well for us, but you know, you have to live near the mountains to try that. So in summary, patients with child often have hypoxemia. Hypoxemia has serious consequences. Oxygen should be used to prevent these consequences. I believe oxygen delivered by low-flow nasal cannula appears to be safe. Patients should not be weaned unless they are clearly getting better, and O2 therapy or increased O2 therapy should be considered for flying. Thank you.
Okay, so we'll open it up for questions for both of you guys. So,
Hello, Dr. Fan, a few years ago I sat by you at a conference and you said, "Where's your daughter?" And I said, "I can't bring her because we would get kicked off the plane because of her erratic behavior." So you answered my question. So even though kids who are satting above 90 seem to do better on oxygen, which I wholeheartedly agree and see every single day, especially in our unplanned experiments where the oxygen is not on at night and we suffer for the next day. And I think y'all saw on the boat last night, she's the redhead who was having meltdowns because she was really tired. Why? Why can she hold her saturations but just freak out completely? I mean, if you watch Big Bang Theory, like we've had her tested, she's not crazy. But when she's on oxygen, she's so much easier. And I see that the studies show a strong correlation. Do you have any theories as to why?
So The only thing I can say is the O2 sat monitors are generally accurate, but they're not perfect. And so there are situations where the saturations may not reflect, what really is happening. So that would be one explanation. And the other is maybe the work of breathing is high, so those saturations are being maintained at a cost. And if you give the oxygen and reduce the cost of work to get that oxygen saturation up there, then things might go easier. But, those things are possibilities, but the truth is I don't really know.
Okay, I was wanting to know, you said that the nasal cannula, that on a slow flow you feel is safe. What would you consider an oxygen level to be safe? I mean, because my son's on 3 continuous oxygen, and I was kind of wondering, like, are there negative long-term effects for someone who has to be on oxygen continuously? And is there a timeline for those effects to start kind of showing themselves?
Yeah. Do you have an opinion?
No, well, the first thing is you're always on the side of give, not give. Let's put it that the first way. When we talk about what you call the effects of high oxygen concentrations giving effects on the lungs, that we know those acutely, but we don't know those long term. And with most long term acute effects, they level out over time. So there's a tolerance. So the first thing is, I say, we really don't know where we're at. So, however, having said that, you need to get 60% to have trouble. It is really hard to get the 60%. It's really hard to get 60%. You really, you may have to, in an adult, a young, a teenager, for example, you got to be close to 5-6 liters, and you are not even close. And what we are using is, and by respect to Leland here, he made great calculations. They calculate on the high side. So the average number maybe a little below that, and Leland said which calls. So, and I deal with the premies quite a bit. It's part of love. So, I haven't look. It's. I walk in and say, I roll my eyes and say what you call. A half a liter of oxygen is not horrible in a premie. It gets close, but it's not horrible. And I deal with ex-premies all the time.
Is there a difference if it's 8 liters on a toddler on a BiPAP mask? If it's really pushing in there?
Well, yes, I would say if it's 8 liters. So if you concentrate the oxygen, in a mask or something, you might be able to get a little bit more. But usually there's enough leak in the system and stuff like that that it's very hard to get to this 60% level, even at these higher flows. And now in hospitals it's fashionable. We use this heated high flow system, and it's actually used for slightly different purposes. But we actually dilute the oxygen down often when we do that, so we give 50% instead of 100%. But, I'd say if you run high flows in a mask, you will get more, but it's really hard to get to 60%. In fact, in the hospital, when we want to give near 180 to 100%, we use these reservoir systems and something called rebreathing, this partial rebreathing techniques to concentrate the oxygen to get that high. So that's how hard it is to give these very high concentrations of oxygen.
I hope my question makes sense. I don't know how to quite phrase it, but you guys suggest an average of, for example, 94 to 95. Is that over a 24-hour period or a 1-hour period? Or because we always struggle, we want to let our kid go run free in the park, so it may be a 1-hour period where he may be deciding into the 80s, but he's running free. So then maybe at night, I think I need to keep him up to 99 to make up for that average. Like how? Explain more about that average.
The first thing is, don't worry about the runaround effects. Remember, they're not adults. It's only adults who get the defects that you can correct. So, say for example, I'm having obstructive sleep apnea. Well, you fix me, but I'll be only relatively fixed. Okay, so kids are very malleable. So if you take them off and they run on the lower level from a pure cognitive point of view, put the oxygen back on, they do fine. They do fine. So the overall goal is very, very different. Like even if you have a kid running around and he's oxygen saturation, you're still talking about, you're not talking about 8 hours of a night desaturated, if you understand what I'm saying. So, and if you look at what's called Gozal, and Gozal is well worth a look at in Chicago now, you know, he fixed them and they went back up. That's a very important thing to say. And that's what's so good about that study. And if you look at the one from 1969 and Neuberger, they fixed them. They went back up. And they had the window. So I wouldn't be worried about running around a little bit. You have to live life sometime, you know?
Yeah. And that's kind of what I mean by we don't know the exact, so, you know, this is really common, and especially in Colorado, oxygen fixes everything. But, you know, if the patient, so we get these overnight pulse ox studies, and they give you this reading, and it says, and they all have this, at least in Colorado, so there was this percentage of time spent less than 90%, if 90% you're cut off. So how much time are you know, is it 10% or is it 5%? Because they all do this, you know, they have these little dips. And so how much is, you know, too much? And I don't think we know. And so, you know, arbitrarily, and this is strictly arbitrarily, we accept, this is during sleep, if the saturations are greater than 90% for 90% of the time, we feel like the patients can be weaned. But we made that up. That is not based on facts. So, you know, but there's no study that has looked at this fine a calibration.
I guess you said an awake sat is not in the clinic, does not predict if a kid is desatting at night. And I'm wondering about the opposite, because like with our son, his recent sleep study showed he needed 3 to 4 liters to keep him at 94% while he was sleeping. But he doesn't use oxygen during the day. His SATs are usually over 90, 92, but we see those behavior things. We see the irritability, and he has huge hypersomnia. He wants to sleep all the time. So at what point do you say, if he's requiring 4 liters at night, why aren't we doing anything during the day? And Leland's heard me ask this like 100 times. and it's a battle.
I don't know.
Yeah.
So that's why you keep asking.
I'm just asking. I'm going to continue asking it, and you'll
I'm
figure it out.
I'm not getting any smarter as I get older. So the answer is I don't know. I would try the oxygen in the daytime just to see if it makes a difference. You've done that, I assume. And does it make a difference? Hard to know.
I think his behavior is better, definitely, if he has it, but we also are dealing with a 10-year-old boy, different from several people here who have little kids that have no choice, so we run into the social issues of
Right.
a 10-year-old and school and getting oxygen.
So the risk in this situation is not the risk of, you know, it's the having to be tethered to the system while you're awake and running around and stuff. You know, I think that's the downside.
We see that, I mean, he retracts hard all day long, and he's, you know, things like, it just seems weird that it requires 4 liters at night, but he can maintain his SATs during the day.
Yeah.
What is the
Yeah, I'd say that, first of all, that's very unusual to have that discrepancy, but, you know, I would try the oxygen in the daytime. Is that what I told you last year?
It's not unusual to see that in the adult world. So the adult world is very frequent, you know. So when you go asleep, you know, most of the parents here, if you go asleep, your oxygen saturation is not 97, 98. It probably is near to 94 for a period of time. So it's not unusual to see, mainly because what happens is the only muscle that breathes while you're deep is the diaphragm. And during the day, you're moving the rest of your muscles. So it really is, there's only one muscle working when you sleep, and that's the reason why it's worse at night. And that's the reason why it's worse at night. So during the day, he's able to cope because he's able to, you know how he says retracting during the day? That means he's using these muscles, but at night he doesn't have that advantage. And that's the reason why you're seeing it. Now, the question about oxygen during the day, I think I'd have tried oxygen during the day, but I'm pretty sure that none of my teenagers would take it. I'm pretty sure.
I think this will probably carry through with what's been said, but from a standpoint of an older child, my daughter's 10, continuous 24/7 from 5 weeks old. So she's in that place of still doing the oxygen all the time. And the saturations are beautiful, but we're still seeing the cognitive. We're still seeing the behavioral. And it's more so in the last probably year and a half that I've seen it. Now, last year at conference, there was a family who's not here this year, and I was really hoping they would be, talked about a study that was being done in Arizona showing that, yes, although a pulmonologist will tell you that saturations at 92 are just fine, which she's above that on 1.5 to 2 liters, but that from a neurological standpoint, the part of the brain dealing with cognitive, 92 is not enough. So when you're dealing with a situation of oxygen over an extended period of time, 10 years of her life, at 1.5 liters to 2, and sometimes at 3, I know you don't have enough data to say, okay, we've had 50 cases. But when the body and the brain are all still in that developmental stage, it's very much different than an adult who at some point in their life had to be on oxygen for 10 years at a time. Their brain wasn't in the developmental stages to say, okay, this part of the brain, although we were maintaining the saturations with oxygen as opposed to just naturally, there was an effect there. Have you heard of that study? Do you know more about that?
But, this is just our understanding of physiology. So, really, the name of the game is oxygen delivery. So, and oxygen delivery is affected by 3 things. So, it's the amount of oxygen you have in your blood, that's what we're all talking about. It's the number of boxcars you have that can carry the cargo to this, wherever you're going. And that's the hemoglobin. So you need an adequate number of red cells to carry that oxygen. And you need a strong pump. You need a good engine, and that's the heart. And so those 3 things affect oxygen delivery to the brain. And the reason why people that live in Leadville, Colorado are fine, the vast majority of them, is because there are compensatory changes that occur that if one of those things is not quite adequate, then the other parts kick in to make up the difference. So people that live in Leadville have a higher hemoglobin than do people that live at sea level. And their cardiac output's a little higher. And actually there's a change in the way the oxygen delivers, which favors them. So, and 90% is, if you look at it in terms of something that we call O2 content, so we focus on saturation and PO2, but it's really O2 content that matters. There's very, very little difference in O2 content between somebody that has a saturation of 90% and somebody that has a saturation of 100%, or even somebody that's breathing 100% oxygen that can get their PO2 up to 500 or 600, that change in O2 content is very small. So I guess I have a little trouble believing that this part, makes a huge difference.
But if
now,
they're labored at 2 liters of oxygen or 1.5 liters, they're still labored and exhausted by noon, and so
Sure.
therefore
Oh, no.
they're not willing to, or their brain isn't in a place to learn because they're
Yeah.
working so
No,
hard
I'm
to
all-
breathe.
I'm-
What would you recommend?
I'm liberal with oxygen, believe me, because I think the downside is minuscule, and the upside is great. So when in doubt, I give oxygen. But I'm just saying in strict physiologic terms, I think there's very little difference in O2 content, and if you look at the oxygen delivery, I would bet that it's the same or pretty close to the same because of these other things that kick in to help you when your sats are lower.
But as you had said, when you have a scenario of an older child breathing in actually getting less because of the way their inspiratory phase is working,
right.
would you then consider, in order to have less laborious breathing and potentially better cognitive learning, to increase that oxygen if you're already at 2 and you've been on it for 10 years' time and with no indication of ever coming on?
Can I just take one question on that? You see, what you really need is a sleep study. Just let me, can I be, yeah, but you need to go back and look at rares. There's a thing called, which you have to understand, there's been a change in the understanding of sleep in the last 10 years. And there's these things called respiratory arousal index. Now, it's not apnea-hypopnea index. Now, and what they do is, it's like you sleep through the whole night, right? And you're just having something there. So you got kicked 50 times and you didn't sleep properly, even though your oxygen saturation's fine. Okay, so if you were kicked 50 times during the night, and right, would you have problems learning, or would Leland and I have problems functioning at work? And the answer is probably yes. Okay, so what you do, there's been a reinvention of this, and what you would have to do is you probably should go back and look at this with sleep specialist, and this respiratory arousal index, and it's a very important number. Even though this thing called, she talked earlier about a thing called apnea-hypopnea index being normal, that may not be the whole story in some sleep. And if you notice that they have this thing in kids. We call an apnea-hypopnea index in kids of 5 terribly abnormal. The adults think a lower number. So you have to look at these rares a little bit more. So the first thing, as I would say, is it depends where it's done. And I'm looking at a nodding head behind me. You really need to go to a pediatric sleep specialist and say, all right, because they're going to look at it differently towards an adult sleep specialist. But if you would ask me that question 10 years ago and asked me about rares, I would have said, what? And so it's looking at how mature the sleep is. And only a sleep specialist is going to be able to get you. We're only going to be able to say the oxygen delivery is fine, but is the sleep structure normal? Is he having, I don't know if he or she, is she having a lot of arousals through the night? Is she having restless leg? All these other things that we take that are eminently treatable and that need to be looked at. But we focus on oxygen so much. So, and when she and there she is, when she put up her slide, there's these other things that we look at. But me, I love oxygen, but there are a lot of other things that need to feed. So I would say, hey, it's a good time to look at other things.
Because that's where we're at, because cognitive is showing in the sort of standard school testing. We're not showing a learning disability, but we're still sitting in the 3rd and 4th percentile for your core subjects, your math, your language arts, and the organizational skills that she has is very limited. And so now we're back to square one with doing, sleep studies and that sort of thing, and yet it would indicate she doesn't have a learning disability. So that's where I'm trying to get at. Where is that over time exposure to that much oxygen, and what you do past that to try and increase and improve the situation? That's a good thing.
So Alejandra had brought up her son, taking him off oxygen to run around a playground. My son's a little different, so oxygen at rest maintains his oxygen saturations, but as soon as he walks across the room, he'll desaturate to 80, and no matter how high you turn his oxygen, and once he starts running, he desaturates to the low 70s, and you can't correct the shunt. So I guess my question is, for a toddler who's 3.5, who can't run around without instantly desaturating, is he at greater risk for cognitive issues? Because it's nice, I want him to be able to run around and play, but I know what's happening, and I can't correct it with any amount of oxygen.
Well, I think we can only go by what Gozell showed, that yes, me an adult, that would be a problem, but kids are very plastic, so when he rests, the oxygen saturation is going to go back up, so I think you're pretty safe. So if you'd ask me, I would, and there's not a huge amount of knowledge base, so I think I'm and I have a few kids just like that, and I deal with this syndrome called HHT, which is they're really blue. Trust me, they are really blue. And I do let them run around.
Is he at higher risk, though, to have more
He-
cognitive effects of it? Because
Probably, but it's not to the degree that you think it is. Because look, if you really look at it, just look at this member study I said, she fixed them. She fixed it. Those kids were really below. Now, they don't have numbers like you're thinking. They have numbers of 60%. And she fixed them at a year, and they did great. If you look at that, so 60% at a year all the time. You know, the story with these kids that they fixed in these studies, they were 60% all the time, and no oxygen made any difference. So, and when she fixed them at a year, they were fine. Now, so I actually think the running around won't cause you much harm, to be quite frank. There's not a huge amount of evidence in my favor, but I think I would be okay. I think, Leland, you'd be saying, yeah.
Okay, we're getting way into the lunchtime, which is fine because we've got a buffet and people are going through. But I want to have time for 1 or 2 last-minute questions. Does anybody have any
Kill me.
else? Okay.
Thank you.
So we'll have a break. We're cutting into lunch, but we'll meet back in here. Was it 1 o'clock? Thank you, guys.